Well, good afternoon, everyone, and welcome to the February 15th edition of the Provider Update Call. Thank you so much for joining. It actually was a very busy end of week in a completely unexpected way. So I think there is actually lots to go over today. Just to start with our overview real quick, the main things that did happen at the end of the week. Well, first of all, the FDA did put on hold looking at the Pfizer's EUA request for the 6 month to 4 years old, which I think all of us breathed a collective sigh of relief that we weren't going to have kind of a half of a recommendation coming through 2 out of 3 doses approved. So disappointing for some who want to get started, but overall probably a good move. And then a whole slew of vaccine recommendation changes came down, ones we have been expecting and talking about, but now they're official. And then a new monoclonal antibody was approved, the bebtelovimab, which I think that's the first time I've said that out loud. So who knows, it's about 50-50 whether I got it right. So community transmission, while cases are coming down and percent positivity is also coming down across the US, it's still a bright red map. Interestingly, though, what goes into this metric is a percent positivity of 10 if it's over 10%, it kicks into the high group. So we're getting there. The percent positivity across the US was 10.98. So I think, as we all are feeling and experiencing, I think getting there. This is New Mexico specific data. Again, our daily new case per 100,000 have come down. Here's the graph. We just got out of our extreme area and into the critical. So that's moving in the right direction. Our positive test rate on this, which I clipped over the weekend, it still looks high, but like on the New Mexico data, which does include more tests, I think we're down to 15%. And then our infection rate, our effective, is as low as it's been really from the beginning of the pandemic. So that's a good sign as well. Also low, though, and maybe not so good, is our weekly vaccine administration. So we are down to 25,600 vaccines for the week. This is kind of a week ago. And, that is unfortunate, but I guess 25,000 is still a fair number of vaccines. And, we'll I guess, what it looks like is it is continuing to drop. I just thought these are some interesting graphs from the New York Times vaccine or data tracker, COVID data tracker, just looking at the much greater risk of unvaccinated cases and deaths. And I just put it in there, I think we still kind of keep getting the question about Omicron and does it really matter? Is it really that bad? Does anyone die from it? And the answer is yes. So COVID patients in the hospitals and ICUs, finally, this is also New Mexico specific. Sorry, it's not really labeled that way, but those numbers we are seeing finally starting to come down. And this is from the New York Times. The New Mexico, the Epi department does put together really nice reports that can be found on the main COVID web page, or a link to it on the main COVID web page. And the only thing is that they update them on Tuesday mornings. And so it's sort of a bad time for me to get updated data into the slides. But this, for example, is from there, just looking at the number of patients hospitalized, ventilator versus no ventilator. And the only thing, again, to just drive home the point that we still saw a lower percent of patients ventilated during Omicron, but still a large number. This is, again, just looking at vaccine, people who've completed vaccine by race and ethnicity, not much has changed there. All right, so now onto the vaccine updates. And I'm sorry, these are not pretty slides. but we'll just sort of talk them through. I'm sure many of you already have this figured out. But the main change, I think the one that will affect the largest number of people in New Mexico, is that boosters for immune compromised people 12 plus following an mRNA primary series and that third dose can now be given a booster. I think I skipped a word in there, at 3 months after the third dose. So that's shortened from 5 months. So everyone else still gets the booster at 5 months. For immune compromised people, they're basically getting 4 doses in, well, not a 3-month period. Let's see, let's add that up. That'll be somewhere, but kind of a total of 5 months. So they get the primary series, it'll be 21 days apart, the first and second dose if you got Pfizer, it'll be 28 days apart if you're doing it with Moderna, then 28 days again for the third dose, and then 3 months later for that booster dose, which again, the booster dose can be mix and match. For immune compromised people, moving on to number 2, 18 plus who got a J&J primary, it is now recommended to get an mRNA second dose at 28 days, followed by a booster 2 months after the second dose. So this is just kind of completely new. So really what you're doing is following a J&J primary in people who are immune compromised with an mRNA dose and an mRNA booster. Now, we know that a lot of people who got J&J as an initial, when the booster the regular old booster, well, when the recommendations came out for boosters, anyone with J&J there was no special recommendation for people who were immune compromised who got J&J in the first place. They've always been kind of left out of this recommendation. So this puts them in the fold. But in the meantime, there's a lot of people who went and got at least some kind of booster with J&J. And so for that group that now show up, there's actually a nice chart for it, which I clipped later in the slides. But the basic thing is if they got a second J&J dose as their booster, then at 2 months from that second J&J dose, they can have a full dose of Moderna or a full dose of Pfizer. For someone who got a J&J dose and followed it with a Pfizer booster, just go ahead and give them a booster in 2 months. And for the person who got the Moderna half-dose booster, go ahead and give them a full dose of Moderna 2 months later. So this is just, anyway, we'll look at the chart. So this is kind of the straight up, people who started with the mRNA primary series. We've been dealing with this group really since, I think, since January 13th, when they all became eligible for that fourth dose when the recommendation was 5 months. So the mRNA primary series, 28 days later, that third primary dose or additional dose. And again, these should match brands. And then 3 months later, the booster dose, and it used to be 5 months. So I don't think this will actually bump up numbers of people by that much, but certainly that we've made it possible to schedule on the schedule in the RTS app, and just good for everyone to be aware. So this is the chart in the CDC interim clinical considerations for use of COVID-19 vaccines, my favorite page. So a lot of the information they did kind of put into chart form, which I think was a good move. That was their latest update. And then this is that guidance for people who are immune compromised and started with Janssen, kind of every iteration that you can think of. So hopefully that will be helpful. The second thing, that the big category, was updates for people vaccinated outside the US with the WHO approved vaccines, but the non-FDA authorized. So for people 12 plus who've had an incomplete series, and again, that's often the AstraZeneca 1 of 2 doses, people can get an age-appropriate mRNA vaccine to complete the series. So previously, only Pfizer was recommended for this group, and that's because Pfizer was the only fully approved vaccine. Once Moderna got fully approved, then the CDC can roll Moderna and Pfizer into these emergency use instructions. So they aren't like part of the FDA, what the FDA signs off on, but what the CDC feels is good clinical guidance. So now pretty much all those ones that were Pfizer only, because Pfizer was the only approved vaccine, now you can get Pfizer or Moderna. And then just to finish the sentence here, and then should get an age-appropriate mRNA booster at 5 months. So this is not an immune compromised group. This is just regular old people who got half, haven't completed something like AstraZeneca. For people 12 plus who have completed a WHO approved but non-FDA authorized vaccine, they can get boosters again at 5 months. It can be either mRNA vaccine, but it should be age appropriate. So again, for the 12 to 17-year-olds, that's only going to be Pfizer. And then the last one kind of in this vein is for immune compromised people, 12 plus, who have started vaccination with a WHO approved but non-FDA authorized vaccine. They should get a third dose of an age-appropriate mRNA vaccine and then a booster at 3 months. So people, basically, the people who started vaccine outside the country with a non-FDA approved vaccine are just going to follow the same schedule. The people 12 plus are going to follow the same schedule that anyone else would who had started down the path of an mRNA vaccine, but and kind of you can jump in at any time with an age-appropriate mRNA vaccine. Now, if you have gotten vaccinated outside the country with a non-WHO approved and non-FDA approved, then you are still going to just start all over again here in the US. And here's the chart that they made that kind of, there's actually a couple of these charts, but this is the one about that halfway, which I think, at least for me at vaccine sites, has usually the more complicated. Okay, just a couple other updates. Vaccines can be given after passive antibody treatment without any waiting period. So this is a big change, one I've been waiting for a while, but so the previous recommendation was that you had to wait 90 days after getting monoclonal antibody to get your vaccine, 30 days if you were given that monoclonal antibody as post-exposure prophylaxis. All of that has gone away. So you can get your monoclonal antibody and 3 days later go and get your vaccine if you are feeling better and out of your isolation period. There's also stronger language to avoid additional doses of mRNA vaccine after COVID vaccine related myocarditis or pericarditis. So it still leaves room for, a different decision, like maybe a really high risk person who's recovered from pericarditis and wants to get vaccinated. And then there's some idea that, like, especially in men who are more likely to get the myocarditis in the first place, that maybe using J&J for that second dose would be okay. The last thing, and this actually is not new, but just because of number one here, the Evusheld, which is the long-acting monoclonal antibody that can be given as pre-exposure prophylaxis, so basically PrEP. It's recommended to administer in its EUA. It's recommended to administer Evusheld 2 weeks after a vaccine dose. So that's kind of the only waiting period, but that's not like if you got COVID, you need to wait. This is just this very specific to when the timing of giving this particular medication. So I just put this in when can I get vaccinated if I test positive for COVID-19? It's just so interesting that what has, like, over and over again in calls that we have with, community groups, we get this question. And, we used to have to say, well, if you got treated with monoclonal antibody, you have to wait. Now you don't have to wait. But even despite I mean, even aside from the monoclonal antibody, people, it seems like commonly held perception that you need to wait 30 or 90 days after you've had COVID in order to get vaccine. So I just kind of throw it out there as, I mean, it's not a horrible myth, but just a little bit seems to be in the collective consciousness to try to dispel. So you basically, CDC just says, wait to be vaccinated until you have recovered from illness. So if you're still coughing like crazy, don't go to a vaccine site. And you have met the criteria for discontinuing isolation. So, you know, basically, I mean, I still tell people, wait the 10 days just because you don't want people standing in line who might still be shedding a few viruses, taking their mask down to talk to you. But, you know, an argument could be made that this really just means, you know, wait the 5 days. This is just a summary. Somehow Dr. Parahone got all this information into one slide. So if you want a one slide look, here it is. And the last thing I have is just this Pfizer maroon cap on hold. We, Joelle had actually placed all the orders, the pre-orders, people who had been interested in ordering in the VTrack system. Those all are canceled by the CDC. No vaccine is going to ship at this point. And basically our state allocation has gone back to 0. So we're really going to have no movement on maroon cap for 6-month to 4-year-olds for now. When it becomes available in the spring, what CDC told us is your canceled orders will remain in VTracks for future reference, but you know, more than likely we'll sort of be starting over again on that whole project. And then these I just left in from last time. And I'm going to take a breath. I think joining us today is Courtney Lovato, who's our DOH head pharmacist. And Courtney, if you're on, do you want to give a therapeutics update?
Yeah, I'm available if you'll click through the slides for me.
All right.
First off, we have a new COVID therapeutic that was approved on February 11th, so last Friday. And I apologize, it was not approved. It was granted an emergency use authorization, which is quite different. We do have supplies that will be going out to hospitals this week. We anticipate it should be arriving in the state early next week by Tuesday or Wednesday. This is a monoclonal antibody. It is going to be authorized for the treatment of mild to moderate COVID-19 disease. It's for patients age 12 and up, and they must weigh a minimum of 40 kilograms. It's given, it's 175 milligrams, given IV is just a 30-second push. And there is an hour observation period since it is under an emergency use authorization. Next slide, please. So typically when we have new therapeutics, the first thing that we like to tell you is how effective they are. We'll usually talk about how much it reduces progression to hospitalization or death. And in this one, it's actually quite unique in that the FDA issued an authorization for this product, although they don't have data on the reduction in progression to hospitalization and death. What they do know is that in the clinical trials that were conducted in Blaze 4, that it did improve symptoms in patients with mild to moderate COVID-19 disease, and it did improve the viral load on day 5. They were able to also determine that this is, for the most part, a very safe medication. And so based off of that information, they granted an approval with the language that it's reasonable to believe that this medication may reduce progression to hospitalization or death. The clinical trials were not powered or designed to determine the difference in clinical outcomes. So next slide, please. It does retain its effect against the circulating variants, in particular Omicron. So this is an option, and I think we added a couple slides in there, but this is an option that we're considering kind of a third tier option. You do want to use your other medications that you know are effective for our high-risk patients. You want to use your Paxlovid, you want to use your sotrovimab, your remdesivir, before looking at options like molnupiravir or bebtelovimab. And then I think Dr. Durham was going to speak a moment about pregnancy.
Yep, sorry, I might have just gotten these slides all out of order with sort of a last minute addition, but I think this was a conversation that came up today, is just with looking at mortality data for pregnant women in New Mexico due to COVID. And so just a reminder that there is, I mean, vaccine is safe and almost all of the treatments are safe for women who are pregnant. Molnupiravir is the one that is not indicated in pregnancy, but definitely refer patients for treatment, and probably we really want them to get the most effective treatments. So sotrovimab or Paxlovid. And so this is just from the CDC intensive care admissions among pregnant women. I mean, the numbers are not huge, but still with all the vaccine and all the options for pregnant women, we really want to see this at zero. This is deaths among pregnant women with COVID-19 by month. And again, this is national data, but still something that is really avoidable. Okay, sorry that. Go ahead. Do you want to take this?
Sure, I can go through this. Sorry for my confusion on that. The other thing that we do want to announce with COVID therapeutics is we have had a very good availability of the products, although we're only receiving limited amounts in the state. Our utilization of all COVID therapeutics is really low. So we're removing the OMAS triage score. It's no longer necessary to use this in order to select patients that are eligible for Paxlovid or sotrovimab. We still recommend that those patients at highest risk of COVID get tier 1 or 2 medications. So that includes patients who are elderly, patients who have comorbid conditions as defined by the CDC. And the more comorbid conditions a patient has, the greater the risk for severe COVID-19 disease. Additionally, the CDC has stated that individuals of color are also at greater risk for severe outcomes from COVID-19 disease, which is another consideration, but we have removed the OMAS score. Next slide, please. And this is a very condensed version of our quick reference guide. We will be sending out a new quick reference guide this week, but I just wanted to really summarize our therapeutics that we now have available and how we've tiered them. So we have our tier 1 medications are the Paxlovid and remdesivir, 87% effective or greater. Sotrovimab, although it is 85% effective, we put that at tier 2, and that's more because we want to differentiate that and make sure that we're reserving this treatment for those who can't receive Paxlovid because of drug interactions, or that can't get access to remdesivir because there isn't a remdesivir infusion site near them. And then finally, our tier 3 medications are those that have less efficacy, or that we don't have data in reduction in hospitalization and death. And these therapeutics should be utilized only when the other options are either contraindicated or unavailable to your patient. And this is a really, really great guide that Lysol made, and it's really an awesome instruction aid for patients regarding the oral therapeutics and the IV medications that are available. We are updating that this week to include the new IV medication, bebtelovimab, and we'll be sending this out. The other thing that we'd really like to point out about this guide is that if patients don't have a medical provider, they can call the coronavirus hotline, and the coronavirus hotline will make sure to connect them to a provider near them, or assist them with the referral process and ensuring that patients are connected with care.
Awesome. And thank you so much. And usually, I think I don't have too much more. I think this was just a cool slide showing the efficacy of masks. And our testing updates, mostly it's just to show that testing has really dropped off, as have cases. Those usually do move hand in hand. And findatestnm.org, again, a great, I think the website's really, great improvements have been made, so you can basically search testing by zip code. And reporting of home tests, these are all from the previous talk. So thanks for all you do. I am going to turn it over to Chris Schroeder and Courtney. I think, did you say there were updates on the therapeutic side?
Yes, we do have a new website that Chris's team has created for us in order to aid in finding where you can get molnupiravir or Paxlovid for your patient, or even sotrovimab and remdesivir. Chris, I don't know if you have the test version available on your webpage and can kind of walk them through it.
Sure.
If not, I can pull it up.
Let's see. Can everybody hear me okay? Okay, great. This is obviously just a development page, but it will highlight some of the functionality that you'll see. So these are all the different sites that have the different medications and therapeutics. We're filtering everything by what's in stock, but as you can see, as new locations become available via Courtney and the team, they will enter this information in so that the public can find the locations that have these therapeutics. So if you wanted to search for, I mess this up all the time,
molnupiravir. I got you, Chris.
Thank you. And I'll just put in my zip code. It will zoom into that particular zip with all of the locations that currently have that particular therapeutic, and then any information that is associated with this particular provider will be available in the green pins, as well as down here in the grid. If you just wanted to see groups that had it in stock, obviously you can filter by that, as well as remdesivir, Evusheld, and sotrovimab. I just want everybody to know that I just nailed those names. These are the intravenous ones. You can see which groups have those in particular. And then if there's any referral requirements, the patient will have whatever referral requirements are there, as much information as possible in order to get them the medications that they need. So this will be coming out hopefully in the next couple of days. We have a couple more things to improve, and then we will be pushing it out for the public to find these medications.
Awesome. All right. Well, let's see. I'm going to scroll to the top of the questions here. The Han, yes, it is making its way through the approval process and will go out. So glad you asked. If a patient gets first vaccine on 12/20, second on 1/21, and then third on 11/21, and they are immune compromised, should they be getting a fourth in 3 months? Yes. Yep, so it's going to be 3 months from that third dose. There are a lot of people where the third dose was delayed by quite a bit, just because of when the recommendation came. Let's see, Sharon's asking, the trade names of MAB or PrEP, are there other names for these? Yes, these are actually the easier of the two to pronounce, but we can get those. And Courtney, I don't know if you have those off the top of your head.
And
But-
I think Leo responded in the chat
Oh.
two down, and so did Will Darwin. Thank you, Will, with the generic for the Evusheld.
Okay, great. And Evusheld again is the PrEP, the long-acting monoclonal combo for people like where you're trying to prevent, where they either aren't thought to respond to the vaccine or have a serious contraindication and can't get vaccine. But basically protection, and that will be like every 6 months that you would need to get that. I think of it as the old, kind of like the old gamma globulin for Hep B, to date myself seriously. Okay, the names of the current maps being utilized. Okay, that one. Okay, there is one question. If safe, I don't understand why it's not approved. I might have lost the thread there, but if you want to unmute and ask, that would be great.
Jaber 17, I believe this was your comment. Perhaps we move on, and then if you
Okay.
can pop on, we'll come back to this.
Yeah, and I think Tanya's comment, please push to the doctors. I had a patient meet OMAS and CP said to wait several days to see if you get worse, and then we could look at Paxlovid. I mean, again, there is no waiting time. And it is hard. Sometimes people don't seem that sick, but again, I'd really, and again, just to kind of pass on information to providers that you work with and to patients. I think some of this is, really taking the message to patients. But if you are at high risk, don't wait to see if you get worse. It's only a 5-day window for the oral therapeutics, and the sooner you start, the better they work. So we really are wanting people just, again, if you're absolutely no risk and you're not feeling that bad, that might be a reasonable decision not to pursue any medication. But again, as we know with this disease, it is so unpredictable. And these, medications are, relatively safe, and there's a number of choices. People should definitely know about them and have the chance to think about them for themselves. Can you repeat the website for reporting positive COVID by home test? Yeah, let me.
I think it's in a comment right below.
Okay, great. And just to repeat, it's not required to report a home test to the state. Obviously, you should report it to your employer or school or important people in your life or contacts. But there are really 2 places that you can report. Thank you, Chris. This particular one is just going to send the data to basically the team that's been getting all the positive results from labs. It does get you, I believe, a little text back about guidance on what to do with that positive test. And you can only report a positive test in this system. You can't report a negative test. They are looking at this data, but it's not going into our daily case counts. So last week on Tuesday, I think they said there were about 800 in there, which is, probably reflects not a lot of uptake. And 400 of them they thought were maybe kind of people basically testing it out. So again, I think it's helpful in that you can get information back about what to do, kind of guiding you towards some of the guidance, but not required. The second way to report a home test is through this NM Notify, and that is our anonymous contact tracing app. I meant to put a slide in there about it because I was actually surprised at the uptake that the state, somewhere like 45% of people in the state, I think, have a smartphone, and a goodly percentage of them, Chris, you might remember these numbers better, or anyone, but have actually signed up to use NM Notify. So that data doesn't go to the state at all, but if you put in a positive home test in there, it will notify the people that you might have been in contact with. So two different ways, neither of them required, both have slightly different angles on those reports. So how often is the therapeutics finder updated?
I can answer that one.
Go ahead.
So go ahead. We're updating the oral therapeutics information daily. Every provider is required to report that on a federal database. So that's what we're pulling the information from. So that is as accurate as the providers are reporting. And then infusions are a little trickier. They're only updated once weekly. So we'll go through and double check the inventories that we've received. But we're also working with Chris to get providers access for the infusion site so that they can toggle their inventory on and off in a more timely manner. But our first priority is to get this website up and running to make it simpler, and then to work on those nice bells and whistles in the upcoming weeks or two.
Yeah, and I just have to say, Courtney and her team, which is not very many people, basically go in every day and update that website to make it easier for providers and patients to have accurate information. So huge amount of work goes into keeping that updated. Oh, and Courtney already answered in the chat. Okay. Are there other questions? Sharon. Oops, you're on mute.
So
oh, there you are.
We're giving vaccinations in the field, and it's been really an effort to try to get the accurate number that we're giving. So we count them as we go along, and then occasionally our numbers will be off. And we try to figure out, okay, why don't we have the right number of vaccinations that we've given in the machine? And we identified two things that happened this past week. There was a guy who was registered twice, and we clicked confirmed to show that we gave the we administered, but he still showed up as being vaccinated, as being a patron who was vaccinated. He counted twice, and we only gave it once. And then there was another young lady who presented, and we started registering her, then realized she was too young to get a booster, and she still registered as a presented and registered, but in the column administered, it said no. So we were able to track why there were different numbers. And I was wondering if anybody else found this, because we're trying to be really careful to make sure we have accurate numbers vaccinated. And we go off the track a couple of times and try to find out why and how.
So this is in the vaccine registration system, Sharon?
Yes.
Okay,
yes.
So if you can send me the confirmation codes of the individual that was in there twice, I'm assuming that there were just two accounts, but we'll confirm that. And then the young lady registering, this has been a number of providers have pointed out that individuals that are young are getting in there. Then when we do some reconnaissance, either they change their age or something. So what's best is if you can send us like the confirmation code along with the details, we can quickly do an analysis to see how those folks are getting in there. And then if they are sneaking through with the rule that's not being applied, we can keep strengthening the rules on the system. Does that sound like a plan? Okay.
Yes, I'll email you, Chris. Thank you.
Thanks, Sharon.
Hey, Chris, it's Jody. The other thing I would recommend is if you want to know how many you gave, your status check should be presented, not confirmed. Because confirmed just represents your appointments that are confirmed for the day. if you select presented or even obs period, depending how quickly you do that, that's going to reflect who you actually vaccinated. So that would, I mean, I would expect my confirmed numbers to be different. So select presented as your status when you want to see how many you gave.
That's really good guidance there, Jody. Sharon, does that make sense?
Except that there's a column that says administered. And most of them say yes. But sometimes in that column, it says no. And that's where the difference lies.
Okay, maybe we can, when it looks like, are you on the rail runner? What we can do is when you get back, give me a call and we can jump on a quick Zoom and take a look at the use case and see if we can quickly expedite the challenges.
Great.
She's
Thank
with
you,
the
Chris and
Vaxmobile.
Jody.
Yeah, that's
Yeah.
awesome.
Yeah,
Yes.
that's the FEMA buses
Oh, sweet.
out in the middle of nowhere, it looks like.
Edgewood.
Edgewood, okay. All right, other questions?
I think we had another in the chat that I can address.
Okay.
It looks like D. Victor stated, forgive me if I missed this, but are we getting an increase in our sotrovimab allocation? I believe there may be a concern that we'll use our allocation up and not have enough for someone that may come in very ill. And this is a really great question. We have been told by the federal government that hopefully by end of March or April that we should have more readily available supplies of therapeutics. For now, we shouldn't be seeing large increases in our sotrovimab allocation. And this probably is going back to the question as to why we removed the OMAS score. We do have quite a bit of Paxlovid and molnupiravir sitting around the state that's not being used. So if we look at that chart that we have, that's going to be in our quick reference guide, really we're taking away this OMAS tool and leaving greater discretion to providers in order to be able to triage very high risk patients who aren't getting care, our pregnant patients who aren't getting care, our patients with comorbid disease who are testing positive and not being referred for an oral therapeutic or a infusion therapy. But if you'll notice on that guidance that we've created, that table, it states that sotrovimab should really be reserved for patients who can't get Paxlovid or remdesivir and are very high risk. So sites that are sotrovimab infusion sites do have the discretion to implement additional criteria or prioritization for their scarce resources until we're able to expand, knowing that if a patient can't get sotrovimab, we also now have molnupiravir and bebtelovimab if we really do have to set aside that last dose of sotrovimab for the patient that we know is going to come in and be very ill. I hope that helps to answer that question a little bit.
And do we, so, I mean, what does the future look like for sotrovimab allocation? Do we have any
We don't have a lot of visibility. We get our sotrovimab allocations on a weekly basis, and outside of that 1 week, we really don't have a lot of visibility, at least until the end of February. We have been told by the federal government we won't see any major increases in sotrovimab. We are expecting in March and April large increases in our oral therapeutics, and we're also hoping that includes sotrovimab, but we really don't have a lot of visibility from the federal government.
All right. Great question. So, yeah, just I guess on the therapeutics, we do keep. I mean, it is amazingly hard to change people's prescribing practices. I know, you know, I've spent years in primary care, so speak from experience. But again, any thoughts you have about kind of spreading the message both to patients and to providers about this really great resource we have in having a lot of oral therapeutics and really having it available everywhere in the state because of the way, because of, Walgreens and largely thanks to Courtney setting up this plan where any provider can prescribe to the community Walgreens and have it shipped out. But in addition to that, it is also in a lot of pharmacies around the state and will be moving to FQHCs with pharmacies as well. So yeah, keep spreading the word. And let's see, was there one last question? Let's see, if a person had a full 2-dose series and a booster and later becomes immune compromised, they do not require a full dose. Dan, are you on the call?
Yes.
Okay. Do you want to, it looks like that's a response to something.
Yeah, no, I think I got this answer, which was that, if a person is not immune compromised, gets their series, and then becomes immune compromised because, they're starting chemo or something, or some other event, are they eligible for the 4th dose? And what I heard back from CDC was, no, if they weren't immune compromised when they got those shots, that stays good. So I thought that was a really interesting one.
Yeah, and I think, I guess a way to think about that is really just that it's kind of your immune status at the time of vaccine is how you respond to that vaccine. And so, I can kind of argue it both ways in my brain, but that's in the end how I am thinking about it. So that if you were not immune compromised at the time of your primary series and your booster, you've been able to make those antibodies and they should still be there even if you enter into treatment. Now, the one caveat to that, there's always a caveat, is which is rare, but for people who are having stem cell, like when their whole bloodlines are getting wiped out, though that group of patients, there is a recommendation to just restart from the beginning on those. And the one last thing I will say, Dan reminded me that there is a little blurb in the CDC that basically says now, because Pfizer and Moderna are fully approved vaccines, it does allow for some provider discretion in making these decisions about the boosters and the 4th doses for immune compromised. It definitely says this should not happen a lot. But I think that language we actually did clip and put in the HAN just to give, there are going to be just some one-off situations that are a little bit hard to figure out. And it's going to be a discussion between you as the vaccine provider and the patient. And, it's giving a little bit of wiggle room for making a clinical decision in those instances. And thank you, Dale. He said he's posting the COVID-19 treatment options on the Pharmacy Association website. And it looks like, Laura, do you have any last thoughts? It looks like maybe you joined the call.
Sorry. Yes. Oh, no.
Oh,
I just wanted to thank you. We can keep these out. Can you hear?
Dr. Panahan, you're kind of going in and out. I read a comment from her earlier asking about if there's suggestions in terms of reaching out to providers and being more effective in terms of communicating with them. If you have suggestions, you can share with us. Please feel free to throw them in the chat.
Sorry.
There you
Sorry,
are.
I go to a different floor in the office, and so sorry about that. Yeah, no, thanks everyone for their comments on how we can reach out more to get more of this information out, and thanks for all your ideas. So I think that'll be really helpful. Yeah, I think part of the battle is trying to get info out because it changes so much. So thank you.
yes.
Also, Dale Tinker, if we built the map and the directory to be able to be imported into websites. So if you guys are willing to host that as well, that resource can be available as well. If we want to connect offline, just let me know and we'll give you the script that you can add to a page. And it'll basically show everything that Courtney and the team are keeping up to date.
And Lisa has a great comment. Are we going to take out the question in the app about the prior COVID treatment? I think we did start a conversation, Chris. I think you were away, but we probably need to go look at that and see if it came out or not. But thank you for the reminder. We also have a paper form that we need to try to keep in sync. All right. Well, please feel free to reach out if there's anything we didn't get to in this call. Thank you so much for joining today and slogging through all these updates. We really appreciate it. And I mean, at this point, who knows what next week will bring, but I guess we'll just leave the appointment or the meeting as is and see what next week brings. All right. Take care, everyone. Thanks again.